This is the Behavioral Observations Podcast with Matt Sikoria, session number 26.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Hey everybody, it's Matt Sikoria, and I'm really excited to bring session 26 of the Behavioral Observations Podcast to you. You know, when I talk with people who aren't behavior analysts, they're sometimes surprised to learn how far we have to drive, you know, whether that we're living in an urban setting and just have to negotiate traffic, or we're in rural areas like I am, you got to go all over the place to see clients and visit schools and things like that. You know, oftentimes we would think nothing about driving an hour to do 2 hours of consultation or to work with someone or whatever, you know. And while that example might be a tad bit extreme, it's not too far off the mark. I'm sure many members who are of the audience who are listening right now can nod their head that they've done something like that before. But what if there was a way to leverage existing technologies to reduce travel-related barriers to providing these types of clinical services? Well, it turns out that other professions, other helping professions, that is, have already answered these questions. You know, there's this growing field of what's called telemedicine or telehealth. And in this episode, I'm really psyched to be joined by Dr. Wendy Machalicek, who shares a lot of her research in this area and really dives deep into all the things you need to know if this is something you're considering doing. So we talk about all sorts of kind of, practical considerations. And I'm going to make a confession in advance. I kind of geeked out a little bit, you know. I mean, having a podcast, you know, you have to have gear to do that and stuff like that. So I kind of went a little bit overboard. I tried to restrain myself a little bit, and but I love talking about that sort of thing. So we got some gear recommendations and things like that. But does this mean that you can just fire up Skype and have a webcam and get going? Not so fast. It turns out there's obviously a lot of ethical considerations that need to be attended to before contemplating this type of telehealth approach to providing clinical services. So she expertly walks us through some of those considerations and, again, talks about some of her research in this area. So as she is from the University of Oregon, we do learn a little bit about what the behavior analytics scene is like out there. And of course, she concludes with some really good advice for new practitioners. So I really hope you enjoy this episode. But before we get to that, I want to just take care of a few housekeeping issues real quick. The first thing is that I will be at ABAI in Denver. I'm really looking forward to that trip. I will be speaking on panel 333 with Megan Miller from session 13 and with Mary Sawyer from the Aubrey Daniels Institute. And we are talking about supervision. The title of our panel discussion is, Are you training a future behavior analyst or an interventionist? Effectively supervising behavior analysts in training. And we got this super marquee spot on the schedule. We are meeting at Sunday from 6 to 6:50 p.m. So kidding aside, if you do attend the convention, please come by and say hello and hope to see you there. Another thing I did want to mention is that we have now approximately 5 continuing education opportunities available. So if you go to behavioralobservations.com /get CEs, you can see what we have. I think I have all 3 of the Greg Hanley episodes. I've got one of the Pat Fryman episodes, which qualifies for an ethics CE, and a primer on behavioral economics with Derek Reed. And I've got more on the way as well. So you might want to keep checking back to that page from time to time. But let's get back to the conversation at hand. So without any further ado, let's hear from Dr. Wendy Machalicek. Dr. Wendy Machalicek, thank you so much for joining me today. How are you?
I'm great. Thanks for having me. This is really an exciting opportunity.
Yeah, I'm really excited to talk about this topic. We're going to talk about all things telemedicine, telehealth, whatever we want to call it, I guess, and talk about that in the context. Yeah, and talk about that in the context of delivering behavior analytics services. You've published some work in this area and doing some really neat research. And I think this is a topic that's near and dear to a lot of behavior analysts' hearts because we spend so much darn time in our cars, going from here and there. So anything that can drive a little bit of efficiency into our work and expand the reach of these services is going to be good for folks to learn about. So, but before we get to that stuff,
Thank you.
Yeah, no problem. Before we get to that stuff, though, I do want to ask you about, how did you decide to become a behavior analyst? How did you first come in contact with the discipline and things like that?
Yeah. So, I think like most behavior analysts, I had that undergraduate course in psychology where you have the one paragraph that says behavior analysis is dead, Skinner is dead, never use the science, it's not part of our science anymore. And, but I was actually an undergrad major in microbiology and a minor in chemistry. And so I was pre-med and I had to work my way through college. So I actually worked on the weekends and after school kind of schedules in institutional settings for adults with developmental disabilities. So I worked in a state school for individuals with intellectual and developmental disabilities and some private facilities as well as group homes. And as part of that, I got to know a lot of individuals who were in those institutional settings because of serious challenging behavior. Mm-hmm. And I got to work closely with the psychologist on those cases. And I was one of the interventionists implementing behavior support plans in that work. I did not work under the behavior specialist in particular, but I was a recreation therapist or a direct care staff. And so I got a little taste of behavior analysis in that way. And it was the most effective component of the person's treatment plan that I saw. And it was the way to get them access to work and the way to get them access to recreational services or to get them into healthcare when they needed to see a doctor. And so that was really my first contact with behavior analysis was through that work. And I wasn't quite sure what I was going to do after that. And I ended up in special education. Mm-hmm. And from there became a behavior analyst.
So where did you study as an undergraduate?
I was at the University of North Texas.
Okay. Very cool. Yeah, working in those group home settings, those residential settings, that was kind of like my first real job out of graduate school, so this is certainly a good opportunity to get your feet wet and do a lot of I see a lot of positive results from a lot of these interventions. So working in those settings is also very challenging as well. So I always kind of tip my hat to anyone who's come up through those settings. So I know if it was anything.
Definitely, it's provided the context for some of my research around addressing challenging behavior and supporting caregivers and teachers in natural settings to address challenging behavior and to prevent it in the first place. And it has really shaped the context of my scholarship and the focus of what I've done all these years. I can't imagine being anything other than a behavior analyst. It's my worldview for sure.
Very nice. So where did you kind of move on to from there? Where did you go to graduate school?
Yeah, I went to graduate school at the University of Texas at Austin, and I worked with Mark O'Reilly. Mm-hmm. Mm-hmm. Yeah, for both my master's and my PhD.
I see. And so now you're out at the University of Oregon.
Yes, I'm at the University of Oregon. I took some pit stops along the way. I went to work at Portland State University as an assistant professor at a teaching university there for a year after grad school. And then I went on to the University of Wisconsin-Madison in the Weizmann Center on a tenure track position for 2 years, and then made my way back to the Pacific Northwest. So I've been here for about 6 years now.
I know it's not necessarily part of the agenda here, but can you? Yeah. I'm just curious because I've always wanted to visit that part of the country, and certainly we can talk about like wine and coffee and beer and all the other cool stuff.
Those are all really good things here.
but I'm curious. Tell me about the behavior analytics scene out in that neck of the woods.
Yeah, we have a really interesting scene here. When I moved here, I think there were about 14 behavior analysts, and 4 of them were within our College of Education. So, and the majority of behavior analysts were concentrated and continue to be concentrated in Portland, so our largest metropolitan city. Since then, we've had legislation passed within our state government to allow for the provision of ABA service to children with autism and youth with autism. This particular insurance legislation actually says that the private and the public insurers have to provide ABA when it's provided by a licensed behavior analyst in the state of Oregon. And for our purposes, that's a BCBA, or an other licensed healthcare provider who practices ABA under the scope of their practice. Which is, that latter part is a little strange, but and we could talk more about that. But we basically have quadrupled the number of behavior analysts in our state since that legislation passed 2 years ago. And we're hitting the ground now and having a true need for more behavior analysts. So if anybody wants to come to the Pacific Northwest and set up shop, there's a lot of room. We have no one to refer to outside of Portland. And even within the Eugene area, although we have growing providers, we have CARD, we have Centria, we have a lot of providers that are trying to get up and going. We're providing some university-based services. There's a real need within Eugene as well as across the state for more providers.
All right. So students who are listening, once you get that,
come to the Northwest. There's good coffee, good beer. Yeah.
Very cool. Probably lots
beautiful
of
hiking.
Yeah, I was gonna say a lot of cool outdoor recreation opportunities and things like that. So, very, very nice. All right, so let's get on to the general topic here. You were kind enough to send me some of the articles that you have written on telehealth or telemedicine. But I guess one starting point would be just to kind of lay down some operational definitions, if you will, of what this means. So if someone is tuning into this podcast and have never heard those terms before, what is your working definition of telehealth or telemedicine, or what if there's a different term that you use to describe these practices?
Mm-hmm. So in our research team, we've used a variety of terms, but we've kind of settled on telehealth as the terminology that we've been using. And really, I just define telehealth, and other professionals have defined telehealth as two-way communication between a clinician and a client, or two clinicians in regards to a client. It could be asynchronous or synchronous, but through the use of telecommunication technology. So it could be through Skype or VSee, so a video conferencing software, or it could be simply through a smartphone, which, maybe you use an app for that, or you're using Google Hangouts. Or it could be, store and forward kind of technology, where the family actually uploads a video of their interactions with their child to a HIPAA compliant cloud-based software, and then you access that and you give them a telephone call. So there's a lot of different softwares and tools and ways of doing telehealth. But it basically means enabling communication at a distance between a clinician and a client or patient, or two clients and a patient. I'm sorry, a client and a patient, or two experts and a patient.
I see. I understand.
Yeah. Sorry.
No worries. So as it relates to, I'm assuming this is somewhat new in the world of behavior analysis. Has it been used? What's the history of this work in other disciplines or professions?
Yeah, so basically, if you Google any medical issue, so cancer, chronic illnesses, so cancer, diabetes, heart disease, or any acute issue like emergency medicine kind of things, like head trauma or dermatological kind of exams, you will find tons of telehealth research. So the medical field and the public health field they're really light years ahead of education or in behavior analysis in terms of where they are with researching telehealth methodology and looking at effects of telehealth. But increasingly, behavior analysts are using telehealth in our practice, in our research. Since 2006, we've had a growth of telehealth research. Dave Wacker's group was one of the first ones. We were one of the first ones at UT Austin to start using telehealth, and usually really using, either more advanced forms of telehealth, like with fiber optic cables and hospital networks, or, more consumer-ready software and materials like laptop computers and Bluetooth headsets and webcams that are connected to that laptop externally. So, it's been used across medical and public health professions, psychiatry, psychology, and it's moving into education as well. So it's been used in school settings as well, increasingly so.
So as it relates to behavior analytic interventions, what are some examples that you have seen that work well for these types of applications? What sort of interventions have been done in this manner? And certainly feel free to discuss anything that you studies or projects, et cetera, that you've been involved with.
Yeah, so telehealth has been used to do functional behavior assessments, to do experimental functional analyses, to conduct preference assessments in natural settings, all of those assessments. It's been used to deliver discrete trial training, behavioral consultation to families, to teachers of children of all ages, and increasingly it's being used in the typical school population as well. So thinking about struggling readers or kids that are struggling with math or teachers that need to deliver specialized instruction, it's being used in the school systems in that way as well. So increasingly, it's being used to leverage that use of that technology in different ways. So initially, the field we kind of started out as saying, can we do this? Can we use this consumer-ready technology that we used to call up grandma and grandpa on the weekends for our kid to say hi? Can we use that to now deliver interventions and to deliver those to people with disabilities in their homes, with their natural caregivers being the interventionist, or sometimes having like an RBT be the interventionist? And we've basically answered that question, I think, and we are starting to leverage telehealth in a slightly different manner. We're starting to use telehealth to address issues around low incidence disabilities. So some of my work recently has focused on assessment and treatment of challenging behavior for children with Fragile X syndrome. And one of the issues that we came across in my collaboration with folks is it's a low incidence disability, and it's difficult to even get enough participants for a randomized control trial. So we run into some issues around recruitment and the cost involved of having people participate in those studies. And so we started to use telehealth as a way to reach an increased number of participants for that kind of research. But also along the way, we found that it's very useful for a primary service provider model. So for interdisciplinary collaboration. So let's say a BCBA is called in on a case where they're addressing challenging behavior. They conduct the experimental functional analysis. And then for the intervention, they work alongside an SLP to select an appropriate MAND for that reinforcer that's maintaining the challenging behavior. So we've been able to use telehealth in some slightly different ways than we have before. One of those is low incidence disabilities. And then, as I mentioned, reaching additional parties. And so part of that is in rural areas and for folks with disparate access kind of issues. So whenever there's shortage of specialists in rural areas or otherwise, like in the state of Oregon, where we simply just don't have enough BCBAs, telehealth is being used to provide supervision to our clinicians on site, and to provide services to families and to individuals with disabilities who typically would not receive those services. The same goes for teachers. So teachers in rural school settings often don't have access to the same specialist support, and telehealth is increasingly being utilized in that manner. So, for example, one of our recent studies with Andy McDuffie at the Mind Institute looked at delivery of a communication and behavioral intervention for adolescents with Fragile X syndrome, and it was parent implemented. So it was a parent implemented intervention that focused around shared book reading, and so they were focused primarily on language targets, but the BCBAs provided consultation at the same time during conjoint telehealth sessions around managing challenging behavior. So an experimental functional analysis was done, a functional behavior assessment, of course, prior to that, and then development of a behavior support plan that could be used within the context of that shared book reading intervention. Then the BCBA and the SLP could both be present on the telehealth call with a family member who was at a different location. So oftentimes we had 3 different calls initiated at once, with the BCBA being in Oregon, the SLP in California, and the family member somewhere else in the United States.
Wow, that's incredible.
Yeah, it was pretty cool to work on a team and to think about how behavior analysts can do some crossover in terms of role release. And some of that primary service provider model is not part of our training as behavior analysts often.
So with regard to the study with trying to get enough participants for investigating issues with individuals with fragile legs. It sounds like telehealth was was a tool to conduct that research because to mitigate the costs associated with bringing people into a clinic and things like that. So it's kind of interesting because originally when I kind of thought about this interview and some of the research that telehealth was investigating the role of telehealth, and then this is kind of like sounds like the other way around. I guess I had it backwards, and this is a tool to help implement some of these investigations and things like that.
No, I mean, sometimes we are focused on, is telehealth an effective mechanism for delivering behavioral consultation for families that otherwise cannot participate in face-to-face interventions, or how does it compare to face-to-face interventions? So we are very much interested in that. The flip side of that, though, is that it is a really cool technology that you can use to deliver interventions at a distance that you typically cannot face-to-face. So if you think about, for instance, the functional behavior assessment of infrequently occurring challenging behavior. That's a difficulty, right? We go into someone's home and they say, well, this is a really serious challenging behavior, but it only happens once a month. I can't quite predict it. The scatter plots don't tell me when it's going to happen. Telehealth provides us one way to actually say, why don't you just give me a call when it happens? And I can take a look at that behavior. So we've been able to kind of covertly address some issues with adolescents in particular who are more aware of their surroundings and they're more aware of the technology use by hiding some of that from them. And so it's kind of covert that you were observing their behavior at times with parents' permission, of course. So their guardians' permission. But
that ties into a question I got from a listener. And so if you'll indulge me, I'll read it because it kind of addresses this a little bit, or at least it's a kind of a piggybacking question. So Diane asks, I want to know if Wendy has had success with using technology to reduce observer effect during observations or assessments of behavior. This person provides home and community-based services to adults, and those observer effects are one of the biggest challenges. She's had difficulty directly observing problem behaviors to conduct a valid analysis.
Mm-hmm. Yeah, we stumbled across this effect. I guess you would say it's a positive side effect, but we stumbled across this in doing telehealth sessions in our research because we noted that some children were reactive to the technology, and we would cover the camera with a piece of paper, and we would use iPad cases that would flip open so that the screen would not show, and we would hide them. So we would sort of strategically place them in the room, the parent would, before they brought the child into the room. Then they would do some sort of neutralizing routine with the child, like blowing bubbles or something else that was preferred. And then they would transition into whatever we were going to do for the assessment or intervention. And so oftentimes, in particular with children who were adolescents with Fragile X who had heightened social anxiety, we would hide the presence of our interventionist or our assessor through the use of technology. So we kind of stumbled upon that within our work with that population, but have continued to use that kind of strategy to minimize disruption and to decrease any sort of social anxiety or observer reactivity that we find. So we have found that to be extremely useful for individuals who are reactive to having an observer in the home, where you have that child who acts perfectly behaved and until you turn the camera on, and then or until you turn the camera off rather. So the parent says, oh, they're acting really, they don't act like this usually they throw a huge tantrum during dinner.
Oh yeah.
It enables you to capture that in real time, and if the parent is wearing a Bluetooth headset and is able to cover their ear so that the child doesn't know, you can really direct the parent's behavior without the child being aware. Now, there are some ethical issues there if you're working with adults in particular in terms of assent for that kind of procedure and consent as well. But I think it has great possibility.
I see. So that kind of leads me into a subsequent question. As I have to confess, I love gear.
Yeah.
I don't know. I have trouble mastering it. Its use. But I always love talking about this kind of tech stuff. So let's talk about you talked about a Bluetooth headset. Let's go through kind of a list of the
Sure.
types of things that folks need if they were thinking about doing these types of interventions in a telehealth model.
Yeah, so I'll just set aside the ethical issues and confidentiality for a moment and talk clearly, just primarily about the gear. So
we'll come back.
Yeah.
To that.
So the basic gear that you need is a laptop computer or a smartphone or a internet-enabled tablet. So on the provider side of things, you need that, and on the parent side of things or the client side of things, you need the same equipment. So you need a laptop computer, an internet-enabled tablet, or a smartphone. So there are some confidentiality concerns with the use of a smartphone that you can get around with use of a tablet or a computer. So in our research, we've primarily used tablets or computers. You need to have a video conferencing software. So if you're going to do synchronous visits with that video conferencing software, you need a HIPAA compliant video conferencing software. We've used VSee most often. And then you need a headset of some sort. So like we're using headphones right now where we're talking to prevent some audio feedback. That's something that's very helpful. For parents and other clients, I like to use Bluetooth headsets. They're a little more expensive, but they enable the parent to hide the technology from their child. And you prevent, since I work in challenging behavior, I'm thinking a lot about dangling cords and children might grab it and hurt the parent. And so we try to minimize the amount of equipment that is accessible to a child. We've often, in our own practice, we've used external web cameras on the parent or client side of things to enable us to get more of a bird's eye view. So really to enable us to have more visualization of the assessment or intervention area so that if the child runs out of the area or the parent needs to stand up for whatever reason, they're still within our field of view. Whereas whenever you're doing Skype to Skype with your family member or a colleague, we're usually sitting down or standing, but we're right in front of the computer screen. I find that to be effective for didactic education sessions, for discussion kind of questions, for greetings and endings of your video conferencing sessions. But once things are up and moving and you're actually doing behavioral skills training with someone or you're coaching them through a routine, then I actually need them to be able to move around. And so we tend to use a external webcam that's connected to a laptop or an internet-enabled tablet. We've also used some of those flippable, they're called clam cases. So we've used some, they're very expensive, but dear to our hearts. They're flippable iPad cases. And so they're actually really great about angling it. So if you put it up on a bookshelf or a dining room table, you can angle it in such a way to get a bird's eye view as well.
Oh wow, that's pretty cool.
Yeah, that's kind of low tech though. So whenever you really look at the gear that's available, you can use remote cameras that you can move. So Stephanie Peterson's group out at Western Michigan University, they've used some really cool sort of movable technology for those web cameras for work with teachers. So teacher consultation, and of course, big in the teacher education world is this thing called Swivl. So it's actually a remote unit that you can control remotely and actually move it around to capture the teacher's instructional behavior better.
I see.
Yeah.
So this kind of feeds into another listener question. Geeta, who is from India and is obviously very curious about delivering services in remote areas. Had a question about the kind of the parent training piece. What obstacles or barriers, if any, have you had as it relates to parent training for these types of using this type of equipment? I know for someone like myself who's can kind of geek out on this sort of thing, I would be like, yeah, let's do this, but I can imagine I have just as many colleagues and friends who are kind of who are more on the Luddite end of acceptance of technology and things like that. So can you talk about how that works?
Yeah. So, I think to a certain extent, families that participate in our research or that uses telehealth technology, are self-selecting, and they're definitely not fearful of technology. We have some families that are a little concerned about their technology use. We've put in place some really specific educational pieces like videos or step-by-step task analyses that tell you how to set up everything. We also try to set up everything before we mail it to a family or to a client. So if it's a teacher, we set up everything that we possibly can, including pairing of the Bluetooth, charging it, and then just making everything as easy as possible. So really reducing the response effort. And then having some alternative means of communication can be helpful. So in case of the technology breakdown, or if there are technological problems, we rely on other forms of communication like telephone calls. Well, I'm just going to call you, or I'll show, if it's somebody nearby, we might have a face-to-face visit to set up all the equipment and run through it with them and actually have them practice while we support them. Now, that's not possible at a distance. And I have a doctoral student right now who actually provides behavioral teleconsultation alongside the Promise Wisconsin project. So that's in Wisconsin and rural areas. And she does everything at a distance with her families, and they're not necessarily the most technologically advanced families. They're SSI families. So she works quite hard at building rapport with them over the telephone so that when they run into technical difficulties, she can walk them through it and they don't feel as stressed out. Whenever we're really talking about remote communities, the first thing that comes to mind for me is what kind of internet connectivity do they have? So if you're talking about, some places in India, there will not be internet connectivity. And so we're really then focused more on telecommunication technology like smartphones that are more readily available for folks and that might not have the bandwidth to allow you to do two-way video conferencing, but that might allow you to do some didactic education around knowledge and advocacy as outcomes, or as an adjunctive to a face-to-face intervention. So there are no real easy answers for using this technology in truly remote locations or places where there's not good internet connectivity, but that's improving all the time.
Great. And can you comment on, I guess, the general sense of social validity as it relates to these types of interventions? Whether that's with a tech-savvy parent or a parent who struggles, or a caregiver who struggles, whether they're a parent or an RBT or whatever.
Yeah. So in our work with teachers and families of children with autism and other developmental disabilities, we've used social validity questionnaires like we would typically use in single case research to assess their perceptions around goals, procedures, and outcomes. And we usually have a separate section around the use of the telehealth equipment and the procedures that are used. Our families tend to rate the use of a telehealth intervention highly. So whether it's a behavioral consultation or more of an educational consultation, our teachers and our parents rate it highly. However, in many instances, our parents are not receiving other services. So whether it's because their child has serious challenging behavior and they've been unable to locate a provider in their community, or they're in a rural area, or they lack childcare, or the parent has a chronic illness and they find it hard to actually participate in parent education sessions that are available in a major city, all those things are usually variables that our participants share. So we have started to program around that, but we find that the convenience of telehealth is one thing that allows folks to not be as concerned about the technical difficulties when they do occur. So whenever we think about telehealth, every time we do a social validity questionnaire with families, they say that it's convenient, that they get to stay in their pajamas, that they don't have to worry about childcare, that it's good to have access to a specialist. Many times they don't have access to a specialist for their concerns, to address their concerns. But then they also say that, yes, there were technical difficulties, or it was frustrating to use the technology, or sometimes it was hard to learn the use of the technology. But when you really ask them, did that sort of overburden you? It depends on how serious the presenting issue was with their child. So whenever we worked with families who have children with significant support needs, they say, absolutely, the technical difficulties are worth it. The inconvenience of dropped calls are totally worth it. I would do it again in a heartbeat. Every family should have this. every day for the rest of their child's life.
Mm-hmm.
But if you look at families who have children with mild to moderate challenging behavior, for instance, I had a student recently complete a dissertation where she looked at families who had children with mild to moderate challenging behavior. And the families, we had a higher attrition rate for one, and the families were less happy, less pleased with the use of telehealth, and said they would prefer face-to-face. And we're not sure that we didn't actually, experimentally evaluate this component, but I think it's a question about there is a certain response effort to learning the use of technology. And we do need, as a field, to figure out how best to determine which families will benefit the most from the use of telehealth and which ones we should just use face-to-face. I also think there's sort of ethical issues around face-to-face versus telehealth, and that, parents really should have a choice. If we're talking about service delivery, it's important for families to be able to have a choice so that they feel like this is something that they're engaged in. Now, outside of applied behavior analysis, people have done a lot more around social validity of telehealth and have found that a variety of different disability categories like cancer survivors or people that have diabetes, that these folks say that the use of telehealth is acceptable and that they want to continue doing it. And in some ways, the convenience part is the piece that outweighs the trouble that they might encounter with the use of technology.
I see. Where I am in New Hampshire, about 45 minutes northwest of us, is the Dartmouth Hitchcock Medical Center, which is a world-class institution, and people in kind of northern New England will travel there, whether it's for cancer treatment or some sort of specialized intervention or whatever. And I just, in having lived here for a dozen years or so, know of many people who make the trek, if as they call it sometimes, whether it's either going up there or going down to the Boston area or whatever. So I can certainly see how a telehealth model would alleviate some of those burdens and thereby generate high levels of acceptability. Certainly. So.
I will say on the end of the therapist side of things. So we've trained school psychologists who are in training to actually deliver behavioral teleconsultation, and they have lower social validity than the parents. So in our studies, they're actually saying, I kind of rather do this face to face.
Really?
Yeah. And I think in part, and what we've sort of discovered is that behavior analysts know how to do behavioral skills training. But behavioral skills training is a little different to do over telehealth. Whenever we're thinking about the modeling component, especially, we can't jump in with the client and show, the interventionist how to do it. So if it's a teacher in their classroom, a behavior specialist might come in and say, the BCBA says, well, let me show you how to do this with Johnny. We can't do that with telehealth. So you have to be creative. You have to use video models. You have to use role play. You have to use virtual role play so that you actually say, I'm going to be the child and you're going to be the interventionist, and I'm going to act as though I'm the child. And we're going to pretend sort of virtual reality in this 2D dimension that we're looking at here. So I think that's the piece that troubles behavior analyst, is that they can't jump in and do the modeling, and that it's more difficult to build rapport. So it's a different skill set, certainly, to build rapport over telehealth than it is face-to-face,
yeah,
I think.
I can see that would be really difficult, especially if you're trying to coach someone on some sort of, prompt fading or errorless type of, strategy that, or if a learner is, encountering difficulty with a particular lesson or whatever, sometimes you have to, at least in my experience, you have to get in there and kind of muck about for a little bit to figure out what the next step is and things like that. So I can kind of see where that would be a challenge from a clinician standpoint.
Absolutely. On the other side of things, like if you think about early intervention, we often say we want the early interventionist to be coaching the family member or coaching the teacher rather than doing the intervention themselves. But what we often see in practice is that the early interventionist is often pulling the child aside and doing the intervention. So even though philosophically we say, no, we're family centered, or we're going to focus on the teacher's skills to build capacity in natural settings, we actually end up seeing the early interventionist jumping in, and telehealth provides a wall, so you can't do that. So that's been another positive side effect that we hadn't initially thought of, but that other researchers have talked about as well.
I see. So we touched briefly upon the topic of ethics and ethical considerations as it relates to using telehealth, but let's dive into that a little bit deeper. So what are some of the main ethical challenges that you see from the use of these types of consult strategies, and how have you guys I say you guys, how have people who spend their time looking at this and things like that address them?
Sure. So the American Telemedicine Association and the American Psychological Association, as well as other professions, have position statements and guidelines on the use of telehealth. So we've used that to guide our use of telehealth, and that's always sort of evolving from our own research team perspective. But if you have a practice and you want to use telehealth, you should think about first of all, some administrative guidelines. Prior to actually having a telehealth encounter with your client, you should inform the parent or the teacher or the client themselves and educate them in real time. So whether that's through telehealth or through face-to-face contact, about everything that's going to happen in terms of the timing of service, how you provide privacy of their data, security, some risk. So what might happen as part of the intervention. So for instance, if you're doing an experimental functional analysis and you have an RBT there, but you want to let the parent know that if serious challenge of behavior occurs, what's the crisis plan? So really having those important conversations up front about billing, of course, mandatory reporting, because now you are in the parent's living room. So making them aware, if it's a parent or the teacher, making them aware that you are now seeing more than you would, or as much as you would during face-to-face encounters. So just making people aware of that, because I think sometimes people forget that piece, because there are some legal issues around that, obviously. So we need to talk about confidentiality and some protocols. So what do I do if the internet cuts out? What's our next step? Or what if this doesn't work? Or at what point will we transition you to face-to-face services if this is not working out for us? How will we know when to transition to prevent some of those muddier issues that might happen in practice whenever you don't lay out those expectations early on? Mm-hmm. The other piece is around confidentiality, of course, and security of any data. And that actually pertains to both sides. So thinking about the parent's equipment as well as the provider's equipment, and making sure that, for instance, the provider's equipment that they use is encrypted. So an encrypted hard drive, encrypted files if they're saving information. So if you're video recording for later data collection or problem solving with another professional like a supervisor, making sure those files are encrypted, your computer is encrypted, and that it goes everywhere with you. You don't leave it in your car. So really, if you're a provider, if you're an agency, to have some really clear policies on the use of technology for telehealth, instead of sort of saying, yeah, sure, you can try telehealth, actually having some clear policies and guidelines on how to use it appropriately and how to use it ethically. So whenever we think about confidentiality, of course, HIPAA compliance comes into play, and making sure that your software is HIPAA compliant, and making sure that the parent side of things, that they're not inadvertently capturing things either. So you don't want them to accidentally be capturing information on a shared computer that they wouldn't otherwise want to share with other folks that are using that computer. So let's say they share the computer with their extended family members, but they don't necessarily want them to see the content of the behavioral skills training. Then you would want to make sure that their computer is not inadvertently sort of capturing that in some fashion. So those are some issues, as well as privacy. So whenever you think about privacy, I need to let the parent know who else might be in the room. So if you share an office, then you need to introduce the parent to everybody that's in the room and make sure they're aware of that. If you have a supervisor watching, they need to be aware of that. The parent should, or the teacher should, expect some sense of privacy. So they're going to expect the same amount of privacy as when you're having a one-on-one conversation with them. And although that might not always be possible, we want to make sure to do our telehealth sessions in as private as place as possible, like with a closed door and hopefully limited interruptions to no interruptions. From the parent side of things, we have some issues around privacy too. So let's say that the parent doesn't want extended family members on the video, but they happen to come into the room. So the parent needs a mechanism to stop the video, or to be able to just low tech sort of cover up the camera to protect their privacy. So those are some things that come to mind for me. It's quite a lot to really prepare for, I think, as an agency to roll out these guidelines, but thankfully there are some professional organizations to help us with that.
Can you remind me, you mentioned was it the American Telehealth?
The American Telemedicine Association.
Okay, telemedicine. Okay.
Mm-hmm.
And I will run this information down and have it in the show notes. And
then there's the APA guidelines, so American Psychological Association. SLPs have their own. BCBAs don't yet.
I see. I can imagine it's probably something that should be working on. Are you aware of any like ABAI working groups or subcommittees or anything like that's looking into this?
I'm not aware of any.
Okay. You mentioned HIPAA compliant software. Do you have any software recommendations or things that you've found that work well for you? And if I don't mean to put you on the spot, so if I can get this information,
Nope.
if you have recommendations off the top of your head, that would be great.
I like VSee. VSee works well for us. We're always concerned because we're doing behavioral skills training and much of our research, or when we're doing this for clinical consultation, we want to have we want to have two windows. So we want to have two windows that are recordable for our purposes. I want the window that shows the client and the child. And I also want to see the window of the supervisor. So this is important for practicing BCBAs, I think. If you are getting supervision from someone or you're supervising someone, you want to be able to capture both sides of that conversation at the same time so that you can review that later. Then VSee works well for that. There's a multitude of ways that you can use to record your software, but VSee has a built-in way to do that. So we've found that to be pretty useful and have had fewer dropped calls because we're a research outfit and we're not having HIPAA compliance kind of issues. We've also used Skype, but that would not be acceptable for most practicing BCBAs.
I see. Okay. And I will run down the VSee software and put that in the show notes as well, where people can kind of learn more about that. So, wow, this is a treasure trove of information. I appreciate it. And again, I'm just kind of the deep dive into the gear is, I think is helpful. And of course, attending to the ethical considerations is
Mm-hmm.
obviously of paramount importance.
Mm-hmm.
So,
yeah, I think some other folks have used Google Hangouts before, and there's other software as well. You just have to be clear about the HIPAA compliance piece.
Are there other guidelines or recommendations for clinicians who are contemplating this that we haven't discussed already?
Mm-hmm. I think that just basically having those privacy and confidentiality pieces in place. Of course, there's also guideline. I mean, you have to consider the competency of the BCBA or anyone else who might be delivering telehealth. So whenever you think about the skills that are needed to deliver the consultation, those are the same skills that are needed to deliver telehealth, but there's a little extra with telehealth. And we haven't done a lot of studies around training people to use telehealth, but we want to make sure that people have basic rapport building skills over the use of telehealth, that they are aware of mandatory reporting guidelines, because you're really in someone's living room, and it's easy to forget that, I think, with the use of telehealth. Yeah, I think those are the main things: privacy, confidentiality, the building appropriate guidelines for when to use telehealth, when to discontinue using telehealth, to ensure that we have some cultural competence and we're understanding of the family's culture as well. There might be instances where the use of telehealth is not considered to be appropriate for a particular family's culture.
I see. Sounds like, you sometimes hear the term soft skills thrown around, and I think there's even a workshop on that at the upcoming ABAI, if I'm not mistaken. And it sounds like you have to have really, really good soft skills to develop those connections in this kind of two-dimensional world. So those are important considerations. So, what other, obviously, we're new to this. Other people have already, kind of started this work. When I say other people, other professions and things like that. But as we're kind of embarking on this journey, if you will, in using these tools, what are some of the future directions for telehealth in the application of behavior analytics services, or the implementation of behavior analytics services? Certainly, what are some research questions that you and your team are kind of looking at and things like that, and where do we need to go with this moving forward?
Yeah, so our research team is really interested in the effectiveness of telehealth behavioral consultation for individuals who have low incidence disabilities like Fragile X. So we're interested in addressing the need for more behavioral intervention research with a low incidence population where we don't have a lot of ABA research. So we are trying to make some inroads in that direction. In addition, we're really interested to leverage the technology in a way to enable us to look at treatment adherence or long-term treatment fidelity when the behavior analyst is not present anymore, and how we can use an operant model of addressing treatment adherence when we're gone. So really building upon that, enabling the technology to allow us to continue to check in post-intervention in a regular fashion that's cost efficient is a way that we're trying to track that and trying to answer some questions around what happens when we leave. So we get the parents to acquire the skills for implementing their child's behavior support plan. The child's challenging behavior drops to 0. It maintains there across the length of our intervention. And then we say, okay, well, we'll see you in a month. We'll follow up with you. Oftentimes in clinical practice, what would happen is that once we discontinue services, some of those children are going to have challenged behavior later on down the road, right? Some of them will maintain services. Some of them their function of their challenging behavior will change. The parent will experience resurgence. Something will happen, that requires some additional consultation. And one of the things that we're really interested in is that natural dip in treatment fidelity after your interventionist leaves, and the behavior gets better and you just stop using the strategies. You're not adhering as much as you should. We're really interested in what happens during that space and how we can affect it with behavior analysis. So we're increasingly interested in using covert mechanisms of observing behavior, as well as following up with parents about their perceptions around why they stop implementing a certain intervention, or what helps support implementation of an intervention in the absence of regular coaching or booster sessions. So with the behavioral teleconsultation study with young children with Fragile X, we're going to be following up with families for 18 months post-intervention and having monthly check-ins around those adherence kind of issues to try to get at what variables might be associated with continued use of behavior support strategies or discontinued use of those strategies. The other thing is really around addressing disparate access and thinking about how we can improve access to populations that haven't routinely been involved in behavior analytics services. And certainly this goes outside of developmental disabilities, but I can really speak to developmental disabilities when we think about a population like Latino families of children with autism, they are diagnosed later. They tend to receive ABA services later if they get it at all. And for instance, in our own state here, we just don't have a lot of bilingual, bicultural providers. And so whenever you think about BCBAs and how many we have in certain geographical context, like rural areas or areas where there's just a shortage of culturally competent specialists or bilingual specialists, then we really could use telehealth in a way to look at the effectiveness of telehealth delivered interventions by bilingual, bicultural interventionists. So that's another way that our team is headed right now, is thinking about how to serve Spanish-speaking populations or African-American populations who might otherwise not be served by BCBAs because of the lack of providers.
I see.
In our own local context.
Well, a couple of very laudable endeavors. Sounds like lots of areas for future research. So, wow, this has been like one of the most fast moving interviews.
Oh.
I really have I've got like pages of notes here. So and again, like I said, I'm trying not to get too excited about the tech piece of it, but that's interesting. It's an interesting component, but also how
interesting piece, yeah.
But also how it merges together with the access to treatment and the ethical considerations, and then of course the training and things like that. It's got a little bit of everything involved in it. So it's certainly a complex issue, and it's very much commendable that you and your research team are devoting precious research resources to looking at these things. So one thing I'd like to ask everyone before I let them go, Wendy, is we have a lot of students of applied behavior analysis who listen to the program, and also BCBAs who are just starting their career, embarking on this kind of in this new field. Do you have any kind of general parting advice for those at that stage of their careers?
That's a great question. So I think as a beginning BCBA, it's important to recognize that you really are just at the bare minimum of knowledge, and that having mentorship continues to be helpful into later years of your career, as well as, so I would say encouraging people to continue that mentorship, not feel like they have to go it alone. Not everybody, I think, is ready straight out of their BCBA to open up shop on the corner, without some continued mentorship or at least some problem solving with a group. The other piece is really thinking carefully about the context in which they want to practice and the other providers that they're going to interact with and interface with. So I find a relative weakness of our BCBA programs is the lack of interdisciplinary teaming sort of practice that folks get. And BCBAs get a bad rap for not wanting to play with others, not to being rigid to other practitioners' recommendations. And sometimes within good reason, I think. But I think that having some additional exposure to working alongside other professionals, if you get the chance to work on an interdisciplinary assessment team or treatment team, or within a system like a school district leadership team, then those are really helpful in shaping that context that you will be in as a practicing BCBA, and give you some of those, I think you were referring to, softer skills around managing those interactions and making them as successful as possible for ultimate improved outcomes for people with disabilities.
Very cool. That's great advice, and that's why it's one of the staple questions I have in the interview format, because everyone usually comes up with something that's really helpful for folks to know, and that's good advice for, I think, anyone, regardless of where they are on the timeline of their careers. So, Wendy, this has been a great conversation. Thank you so much for joining me today, and hopefully we'll have you back sometime as we start to learn more about all things telehealth and telemedicine.
Yeah, this has been great, Matt. Thank you so much.
My pleasure. Take care.
Great fun. Thanks.
Hey everyone, it's just me. I just wrapping up this episode here, and boy, did Wendy end on a really important note. The importance of mentorship and ongoing education are crucial to a good career in the world of behavior analysis. So I just wanted to take a second to underscore that, and certainly to thank you guys for listening and to thank Wendy for coming on the show. So if you're out driving around, and you want to know more about some of the stuff we talked about, head on over to behavioralobservations.com, session 26, and there'll be links to all of the things that we talked about, some of the gear, some of the like the American Telemedicine Association, the Oregon Behavior Analysis Association too. So if those of you who are interested in checking out the behavior analysis scene out there, there's more info. And I think that's going to do it for today. I hope to see you guys at ABAI. And until the next time, we'll see you in session 27. All right, take care.
Thank you for listening to the Behavioral Observations Podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.